Have you ever read a patient chart and you were trying to figure out, am I decoding a medical emergency or am I trying to figure out somebody's Wi-Fi password?
Because apparently 54-year-old M with PMH of HTN, DM2, GERD, CO, epigastric pain is a normal sentence. Okay, well, fear not, because today we are translating and decoding the unique lingo of nursing. This is the Nursing Navigator by Hurst Review.
Nursing Navigator's here. Wipe away those study tears. Hurst Review's got your back. Listen close, stay on track.
Hey, Sarah, before we get started with today's episode talking about nurse lingo, I saw this trend online and I really think this would be a great way to kick off the podcast for this topic. Okay. So I've got an HPI that I want you to read and just see how you do, okay?
Okay.
All right.
For starters, I have no idea what an HPI is.
Oh, I know. And it's okay because, non-nurse versus nurse. We just want you to just read it.
Okay, I've seen these and I really have no idea what it is. Okay. 50-year-old male with premenstrual history of hematitis at night, dilated membranes ×2, and GERD presents to emergency department, care of acute onset epigastric pain radiating to the back for 3 hours. Denies clinical practitioner, SOB, I don't think I can say that, or dysuria. Patient is awake, angry, and on oxygen for 4 hours. Will reorder pancreatitis, labs, and imaging ordered. Not puking orally for now.
Excellent.
How did I do?
Excellent.
Maybe actually after the episode today, we can revisit this and then see how much I learned. So I'm going to need you to kind of be my translator today.
Gotcha.
All right. So before we get into what these abbreviations are and what the phrases are, let's just kind of roll it back a little bit and talk about why. Like, why are there so many and why is this so unique to the medical world?
For sure. So when it comes to the way that nurses and even other healthcare providers use terminology like that is mainly they're talking in the way that they would document. What you read was an order from a primary healthcare provider, and it was for the nurse to perform what the nurse needed to do for the care of the client. And so they write that in a way that makes it more efficient. So basically a unique form of shorthand. Okay. So that way we can quickly do what we need to do.
Is this something that you study in nursing school? Because that's a long list.
It is. It is a very long list. And there are going to be unique abbreviations that not all nurses learn in nursing school because each unit has their own language. But some of these abbreviations are talked about in nursing school, and we practice how to document in that way. But we also learn how to read the primary healthcare provider's orders. So that way we understand what they're saying.
So you're not reading it the way that I'm sure I just completely butchered it.
Hey, in the beginning, yes.
But ED, I know that's emergency department.
Yes, you did great.
Well, I guess it could be something else. But.
It could be. Well, it actually could be. It could be something else. I just caught on. But typically when it's written that way, it is talking about the emergency department.
Yeah. And if you transfer hospitals or transfer departments or floors, I would assume that there's a standard, right? There's a standard that no matter what hospital you worked at or came from or are going to, like you said, like there's kind of that foundational one, but then maybe, pediatrics is going, or peds.
Yeah.
Right? Because we even have abbreviations for different departments are going to have ones very specific to their practice.
That's right. It's not uncommon that if you switch units, that there might be some abbreviations or terminology that's used that's medically approved that you just aren't aware of. And so you'll learn, as you start working in those areas what those are. But there are some universal ones that no matter where you work, they all work for that.
I just heard you emphasize medically approved.
Oh, yeah.
Are you leading on to that there's like certain terms that are medically approved and then certain terms that are not medically approved?
Yes. And so you've got some that you could use in your documentation, and that would be for legal purposes. And so if you're using non-medically approved abbreviations in your documentation, that's going to go in the client's record. The problem with that is that if that gets pulled in a court case, a lawsuit, anything like that, they could use that against you. They could use that against the nurse. And so we don't want that. We want to make sure that we're using the terminology that's medically approved in our documentation. Okay, so today, the list that we're going to go over, mainly we're going to focus on medically approved abbreviations. So that way this helps you with your documentation. But just for fun, we'll also throw in a few that are non-medically approved that will help with your nurse-to-nurse conversations.
Well, I'm excited to get into that list a little bit later on. And you'll have to stay tuned because some of them on here I have a lot of questions about. But you mentioned court cases and, if somebody were to sue or file an insurance claim.
Just like lawsuits and legal cases, we also want to make sure that we're doing it for insurance purposes. We don't want any claim to get denied just because we didn't document the right way. So we want to make sure that we're, doing that to make sure the client gets exactly what they need.
Yeah, it's really important to dot all your I's and cross all your T's.
That's right.
Now, when it comes to like the patient side of it, do you speak that way to a patient, or do you have to switch over to like your layman's terms or even like the non-medically approved ones, like tummy ache, for example?
For sure. It's going to always be best in that situation to switch because if I told a client their condition typically in the medical terminology, they may not know what that is unless they're in the medical field. And so if you know that information offhand, then that may be okay. But also you have to think about the fact, what area in the medical field are they in? Or do they work in this area or not? And they might not know some of these medically approved abbreviations. So typically it's always best to switch to layman's terms and explain things in a way that they would understand. But you also need to make sure that you are age specific in the way that you describe things too. And so, you have to take in level of education when you're thinking of that. And so I wouldn't describe pain exactly the same to an adult as I would to a 5-year-old. I might, instead of using a certain scale like 0 to 10 on the pain scale for an adult, I wouldn't use that for a 5-year-old. I'd say, let's look at these faces and tell me which face matches.
I remember the faces.
Yeah.
Are you like this, 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 this?
That was like perfect.
Thank you. I practiced in the mirror.
It was very good.
So we take all that into consideration. However, what happens if you have a patient come in or a client come in who may be really, really into medical dramas and spends a lot of their time in the evenings watching all these, Grey's Anatomy, House, there's a million out there, where they feel like they understand medical terms, so they try to meet you at your level.
Right.
And describe their symptoms using medical terminology that I can imagine 9 times out of 10 is probably not a true, accurate representation of how they're actually feeling.
Right. And sometimes, sometimes they're right. Sometimes they've watched enough and the issue that they're experiencing matches exactly what they saw on their TV dramas, and they're right. But one of the things that we want to make sure of is that they do truly understand what is going on. And so if we see, that happening, I always want to ask, and I'm kind of bad about it. I do. I'm like, what do you do? Like, if I don't have that information, I'm like, are you a nurse or are you in the medical field? Are you a physician? I want to know these things. And most of the time, they're very proud to tell you that they're not. They're like, oh no, I do this. And it's like, oh, okay. And I'm like, what? You know a lot of medical terminology. And they're like, oh, thanks. I've been watching Grey's.
Guilty.
Guilty. And again, the only thing bad about that is that sometimes it just doesn't match. If they've got it, they've got it. But we do want to make sure that they do fully understand whatever is going on with them is actually what they think is going on with them. We do not want them running around telling, people that they have a certain medical condition that they don't have.
Oh, yeah. Or even that, the good old Dr. Google told them
yeah.
that they have, because as soon as you put in 2 symptoms into Google, it's like, oh my gosh,
Yeah.
like I have 2 days to live.
You do.
Yeah.
48 hours. Get your affairs in order right now because that is it.
Yeah. But even then, I mean, I've done that before. I've typed in, okay, this is like what I'm feeling.
Mhm.
And then when I go to the doctor to be treated, it's like, okay, are you sure I don't have this and this and this? Because that's what I read online. And I'm
Right.
sure that happens in a lot of environments.
It does. It does. And
Turns out it's just a strep throat.
that's right. And so, we want our patients to become really good advocates for themselves. But that comes, I think, with trust in your healthcare provider team. And we can, start to have those conversations together where they can start to pick up on things that are happening within themselves and then be able to present that to someone else. And so we don't want to dismiss the client ever because, sometimes they're right. Sometimes they've looked up some things and they're actually right. And so we don't want to be dismissive, but we also want to make sure that, we're developing those trusting relationships where they feel comfortable bringing that to us, but in a way that we can also turn around and say, now, you don't have that.
Yeah.
And then they're not offended.
Well, you mentioned healthcare team.
Mhm.
And I think that's something that is important to provide additional insight to, especially when we talk about like the lingo of nursing, because you are working on a team and your shift could end and you could hand off your chart and your documentation to the incoming nurse and they're going to see it all on there. So I'm sure that that's another reason why nurses have a very specific language,
That's right.
because there's going to be some of that changeover and turnover. Or maybe, it's beyond nursing. Maybe the doctor comes in to the picture and they've got to know what's going on too.
Sure.
Ashley, thank you for providing some background as we kind of get into this list. So are you
Okay.
ready to start with medical abbreviations and terms?
I'm a little nervous, but I'm going to do the best I can.
Okay. I'm already seeing a couple on here that now I know I messed up on that little game that we played in the beginning. Okay. So NPO.
Okay. And so when I tell you what this means, you're going to be like, huh? Like, that doesn't sound like it matches. It's nothing by mouth.
NPO.
Yeah.
Nothing by mouth.
Nothing by mouth.
This has got to be stemming from Latin.
Oh, it's for sure, right?
Okay.
Like, you took Latin.
I took Latin.
Yes, girl.
Yeah.
And so I think it's nil per os. Latin people will kill me too. Like anybody very versed in Latin, I probably butchered that. But a lot of the terminology that you see will stem from that. And so if it doesn't seem like it matches, that's why.
Okay.
Nobody's walking around saying nil per os.
I think this next one might fall into that category as well. PRN.
Okay, so that one's as needed. And I don't even remember what that one is.
I've got it written down here. Pro re nada.
Okay.
Of course. Stat.
Right now.
Right now.
At this moment, happening right now.
Of course, I do that one. Again, confessing that I watch medical dramas and it's always like, oh, we need the O2 stat.
Very good.
Yeah. Thank you.
So can I ask you a question while we're on stat and medical dramas?
Mhm.
Do you ever notice anything that seems off about your medical dramas when you watch it?
No, I mean, I really just watch it for like the entertainment purpose of
okay.
it. But I think I know where you might be going with this because you have been trained. This is where you are educated and you actually educate others.
Right.
So I'm sure there's times where you're like, that's not actually right.
It's all the time when we're watching it, and I feel like I'm not the only one. I think most nurses do this. Probably a lot of other healthcare professionals do this too. And I'm thinking there is no way that they have, hired nurse writers or at least a healthcare professional, a physician, someone to help them on their writing team because what is that? Like, that is not an IV catheter. What is that in that client's hand? Like, tell me right now what that is. And so, when we're watching those medical dramas, we are eating them up, like picking it apart, trying to find what's wrong with it. I was just curious if other people did that.
I'm sure there's a lot of people that do that.
Oh, yeah.
Just try to watch it through the non-nurse lens
That's-
and you'll enjoy it.
I don't know. I try and still pick up on it.
We have a Q2H.
Okay, so the Q means every. So basically, this is about how often you would do something. And the H is hours. And so whatever number they put in the middle is how often you would do that. So the Q2H is every 2 hours. Of course, you could change the time 4, 6, however.
What if it's less than an hour? So if it's every 30 minutes, would you say like Q.5H?
Well, you would usually just put the 30. And so you could say 30 minutes. And you can change the H to min.
Okay. DNR. This is another one that I know from the dramas.
You go for it. You know this
Do
one.
not resuscitate.
Yes. Very good.
Then we also have on here a DNI. I don't think I've heard that one before. I'm assuming it's do not I. Could it be incubate?
Close. Intubate. Okay.
Incubate is what you do to chickens.
And babies.
And babies.
Yes.
Do not intubate. All right. This one was in the game that we played earlier.
Okay.
And I was a little scared to say what I wanted to say, so I didn't say it.
Mm-hmm.
But we have SOB.
Okay, it is not what you were thinking. It's not a curse word. If you ever see anybody in the room, like you said, if the nurse is, in the room and they say this, it is shortness of breath. It's still definitely something we don't want to have, but not talking about the patient.
Okay, sure. That makes a lot more sense.
Yes.
TID.
Okay, so that one is talking about how many times a day. So TID is 3 times a day. And then you might see that BID, which is twice a day. Another one of those weird.
Yeah. So BID, could that also be Q12H?
Yeah,
Oh.
It could. Very good.
Really?
It could be.
Oh, okay.
Yeah. And so it just depends, like if they want to do it twice a day, then they really may want to do it at certain times throughout the day versus doing it at 12 hours and then another 12 hours. Because what that could end up looking like is 2 o'clock in the afternoon and then 2 o'clock in the morning, right? And so sometimes they'll use it that way because they want you to do it twice during the actual client's awake hours.
Oh, yeah. Okay, that makes sense. Oh, I've seen this one, Ashley, before on our daily questions that we post on social media. NS.
Oh, okay. And so the funny thing about NS is that, yes, that would be the way that you might see it written, but that's not the way that we would say it. And so NS is normal saline. We would just typically just say it out, normal saline. You might also see that documented as 0.9% NS, normal saline. But if we were talking, I wouldn't say, hey, go grab me a bag of NS.
Okay. Stat.
Yeah, stat. Add that in there. Hey, but we would, sometimes it's different ways you say things versus sometimes the way you document it. And that would be a perfect example of that.
Oh, well, I'm glad we got a good example in there.
Yeah.
Okay, we have GCS.
All right, so GCS is the Glasgow Coma Scale. And so sometimes people are like, well, what's that?
Yeah.
It's the
Sounds
scale.
like a guy's name.
Yep.
Probably.
Well, it is definitely named after someone.
Yeah.
And it is the, way that we measure the level of degree of consciousness for someone. So we use that for coma. Yep. Very
okay.
good.
This is another one that I recognize. DKA. I know it has to do with diabetes.
Yes.
Because we cover that in our free marketing sessions.
Yes, we do. And so diabetic ketoacidosis. That's a long one.
That is a long one.
So
DKA sounds better than saying it out loud every time.
For sure. And, that's another reason why we sometimes use those abbreviations. Because think about if you were in an emergency situation and you were having a conversation with another healthcare provider and you needed to do something very quickly, we would not sit there and say diabetic ketoacidosis.
Yeah, that's a really good point. You just
spit it out.
Go through it.
Right. It's so much quicker, just to say DKA.
Yeah.
And everybody already knows what we're talking about. The patient might not. And that's where we can do some, patient information and education on the back end when they're healthy and they're learning about what's going on with them. But when we're in those emergency situations, we're going to spit it out.
Oh, yeah. You don't need to sit and explain everything to the patient. And those when time is very critical.
Right.
So those kind of covered our abbreviations. But we also have some phrases. So I'm curious for you to kind of break these down for me, too.
For sure.
Because the first one, I thought we were going on a trip or something like that. It's frequent flyer and I just want to say, oh, my frequent flyer miles, because as a non-nurse,
For sure.
frequent flyer means something to me, but I'm curious to hear what it means to you and other medical professionals.
Well, what's funny is that, that's right. When you're talking about a frequent flyer, yeah, you're collecting all your miles and your points and all of that. But for the medical profession, when you have somebody that you're referring to as a frequent flyer, this is a person who continues to come in experiencing the same problem over and over again. And so a perfect example of that is maybe you have a client with diabetes and they keep coming back in experiencing DKA from something maybe as simple as they didn't take enough insulin or they skipped a dose of insulin, or they're doing everything that they're supposed to do and they just keep experiencing DKA. That typically means maybe their dosage of insulin is not right. And so we would refer to them as a frequent flyer.
It's a shame that they can't stack up those miles
I
to
know.
help pay for
There's
for
no
something.
hospital miles, like free healthcare, free hospital miles.
Yeah. And then here we have a repeat offender.
Okay. And so I want you to think about that one. It's not jail. Okay. But if you were thinking about somebody in the hospital setting and we said they're a repeat offender, what do you think that means?
I probably would think that it means something similar to a frequent flyer.
Yep.
And so maybe they could be both a frequent flyer and a repeat offender
For
if
sure.
they're not following through or maybe taking some of that medicine or insulin.
Exactly. And so that would be what we would usually refer to for that client, especially the one that, wasn't doing the treatment plan that was set forth for them and they keep experiencing the same thing, like a repeat offender. Like we keep coming back in for the same thing and we've got a treatment plan and we're not following it. And so we're not going to get a different result by not following this plan.
Yep. You know what they say about insanity? It's doing the same thing over and over
That's
again,
right.
expecting a different response.
That's right.
I like this one. This has a lot more positive vibe to it.
Okay.
Our Rockstar Patients.
Well, it's exactly what you thought. Like it felt positive. It definitely is positive. The Rockstar Patient is the patient that basically just does everything that is outlined. They've tried to follow their treatment plan to the best of their ability. They want to learn about what's going on with them. They bring in other family members to learn so that way they're really comfortable when they get home. But they also are the type of patient that they're there to get care and they're trying to do things for you. Like they want to, send the family member to go get food. And we're like, wait, you don't have to do that.
They're like, hey, what's your Starbucks order?
Right.
I'll get you something.
And they'll do things like, bring you coffee, bring you treats. And we're like, you do not have to do that. But they also stay off the call light, unless they really need to hit it. And it's just like, oh, this is just the best Rockstar Patient ever.
All right. This next one makes me question, have we replaced pagers? Because you know how in Back to the Medical Dramas, I know, but how they their pagers are always beeping. Have we replaced them with walkie talkies? Because that's on here.
We haven't.
No.
No.
Okay. So then what is a walkie talkie?
A walkie talkie is actually referring to the patient. Now, that's not something that we would ever write in our, documentation, but it's referring to a patient that can walk and talk. So they are speaking. So if you talk to them, they can talk back to you. And then they're ambulatory, which just means they're able to walk. So a walkie-talkie.
A walkie-talkie.
And sometimes that's your best patient. And sometimes it's like, no, please sit down.
They're on the run.
They're on the run.
So that's important to note. I'm glad that you said this isn't something that we would chart.
Right.
Would you chart or non-chart sundowning?
Okay, and so usually you would not chart sundowning. That would be more of a conversational topic between, medical professionals. It is okay to have that conversation with the family members and use that terminology. What it typically is referring to is a client with dementia or Alzheimer's. It could also be referring to just a client where things have gone left as the sun has gone down. So typically, if you're talking about a client with dementia, what you might notice is that as the sun is up, they might be more alert and aware and oriented, and they can have a conversation with you. But as the sun starts to go down, they begin to forget, or they might even become a little disoriented. Mm-hmm. And so that's a phenomenon that's referred to as sundowning. So because it's not technically a medical diagnosis, then we wouldn't usually use that in our documented, information, but we could have that conversation together and with the family too.
Yeah. I feel like that would be kind of important to know, especially if they have, a family member taking care of them or a caretaker at home. Just say, hey, in the evenings and when the sun goes down, pay a little bit of extra attention.
That's right.
Or don't be surprised if you see this happen.
That's right.
Okay. This next one takes me back to going to baseball games as a kid. It's called a slam and run.
Oh, well, we're definitely not playing a sport with this one, but it might actually kind of feel a little bit like a sport. Okay, and so this is the situation where you needed to run in the patient's room and basically start fluids and run them really quickly, or give them a medication really quickly and then leave.
Okay.
So you have a situation where most nurses are not taking care of just one patient unless they're working in the ICU. And even in some situations when they work in the ICU, they're not one-on-one. And so if they've got more than one patient, they may have to run in a patient's room, do something really quickly, and then run out.
Slam and run.
Slam and run.
On to the next one.
Yeah.
Then we have sharking. I don't think it's Shark Week right now.
No, it's not. But it'll feel like Shark Week sometimes on the floor when you've got 5 patients that all need the bladder scanner and there's only one bladder scanner in the entire hospital. And so you'll run to the other unit and stand there and wait for somebody to finish using the bladder scanner so you can steal it.
That's what sharking
is. Yes.
Oh, okay.
It's kind of like hovering, waiting around, trying to get whatever, items that you need or to be able to do a procedure because somebody's waiting in line. Somebody's waiting right behind you trying to get it too.
Gotcha. Like good old Black Friday, old school Black Friday.
It is.
I gotta get this. All right. So now we have something called a Fluff and Buff.
Oh, our patients actually love this because, they've been with us for a while and they're comfortable with us. But what if they have to go somewhere else? Or what if they have visitors coming in and they want to look and, their best selves? They want to be very presentable. So this is like a really quick way of tidying up the client or their room and getting them prepped for visitors or to go off the unit.
Gotcha. You want to know what I call that in my household when we've got guests coming over?
What?
A stuff and fluff. Just
Absolutely.
stuff it in a closet and fluff out the pillows to make it look good.
That's right.
So
They'll
basically,
never know.
same thing.
That's the place that they don't go looking. They're not looking in your closet.
Yeah. Well, unless you're, never mind.
Yeah, that can happen. I already know where you're going.
I won't say names. Okay. Well, I'm feeling more and more confident the more we go through these abbreviations and these phrases and descriptors that the next time I see one of those situations, or what did you call an HPI?
Yes.
Show up on the feed, I'll be able to follow along a little bit more, especially after we get through this last list. Are you ready?
For sure, I'm ready.
Some more abbreviations.
Okay.
ADL.
Okay, so that's activities of daily living. And so those are the common things that we all do, throughout the day. Like, are you able to wash your face and brush your teeth, perform any other hygiene yourself? Can you wash your own clothes or ambulate? Any of those things, any of those activities of just daily life, are you able to perform those yourself?
That kind of makes me think of what I think this next one could be.
Okay.
DILO. Is that like day in the life of?
Yes.
Or like those, because I see those on social media.
That's
They're
right.
like, this is like day in the life of a nursing student, day
That's
in the
right.
life of going to work.
And I don't even know, do they use that like hashtag DILO?
I think
that?
it's usually DIL
Okay, DIL.
or DIML.
Okay.
Day in my life. Yeah.
Got it. Okay, but that's what it is. Okay, DILO is just day in life of. So we're talking about like how we function, what we do as nurses.
So what are your ADL and your DILO?
Well, I'm, able to perform all of my activities of daily living. I have nothing that is limiting me on those. And, my day is different every day.
Mm-hmm.
And so I love that, though. I love the fact that I have that flexibility and fun in what we do here at Hurst Review because it's never the same.
It's never the same. And actually, you are going to be like, oh, Sarah, we filmed one episode where we went over nursing lingo, and I'm just going to be pulling these out left and right from here on out. Let's see. Another abbreviation we have is TLC, and I'm guessing that is not tender love and care.
So that is just a way to refer to a triple lumen catheter. That's a central line. Okay, yeah, so it's an IV.
Okay.
Yeah, so it's a type of an IV that is centrally located. So that just means that it's, basically going into the right atrium. It's going into the heart. And I know that's a little bit, panicking to the patient, but that's a really good way to give fluids, especially if you have to give anything that is caustic, which just means eats up, like damaging to the vein. So there's certain, fluids you don't necessarily want to give peripherally, which is, how sometimes when they start an IV, they just start it in your hand or they start it in your arm. Well, certain fluids can damage the vein really easily. And so especially if we have to give a lot of those fluids, we'll want a central line. And most of your central lines are triple lumen, which just means they have 3 little ports, 3 little lines coming off of them. And you can use each port for different things.
So a catheter, you said a triple lumen catheter. So a catheter is not always like what I'm thinking a catheter is.
Oh, no. No. Okay, so you were thinking
That's why I was like, oh my gosh, 3 things. Like,
Well, no, and it was really good. Like you knew that was called a catheter. So like a Foley. You got a Foley catheter. This one's not a urinary catheter.
Okay, so there's different types of catheters. I did not know that.
They call your IV line a catheter.
Oh.
Yeah.
Okay.
So learning something new every day.
Yeah, next time for whatever reason, I have to get a catheter, I'm going to say, what kind of catheter is this
what
again?
Kind?
Where's it going?
Make sure your urinary catheter is not triple lumen.
Yeah. Yes, please. We've got a couple more here. We have a PERRLA.
Okay, so PERRLA is actually talking about your eyes, your pupils. And so you know how if you were in a room and there was a lot of light.
They get really tiny.
That's right. Yep.
And then when I go into a dark room, they like expand so they can let more light in.
That's exactly right.
I know that.
And so good, because what's great about that is that's what we want to see. With your pupils is that so if, you've seen the physician kind of like quickly shine the light in your eye and they're looking, that's what they're trying to see. They're trying to see if your pupils are equal, round, and reactive to light and accommodation.
Oh, so
PERRLA.
Really PERRLA.
This is one of the ones that actually matches what we're saying versus Latin. So
it's not Latin.
A lot easier to grasp.
Gotcha. TURP. You can leave that.
And then with the
Thomas is like, please stop.
With the extra P.
TURP.
It's a surgical procedure where it stands for, and it actually stands for what it is in this situation.
We love these.
I know, not Latin. Again, it's transurethral resection of the prostate.
Oh.
And so, urology term where they're going in, removing a portion of the client's prostate.
NAD. NAD.
Okay. And so that one kind of sounds a little weird too. But that one is a quick way of saying no apparent distress. So, some people might actually say no distress noted if they were documenting, like writing.
So that is a documenting term.
Yeah, they can. Always with anything like that, you want to find out what's unit specific. What you kind of want to try to document like everybody else is. But that one's just a really quick way of saying that one, NAD.
No apparent
distress.
All right, and this next one, I know what it is. Soap. Like, I would hope soap is in it's in every hospital room, waiting room, bathroom.
It is.
We've got to be talking about something else.
We
here.
are.
Okay.
We are definitely talking about something
wash
else.
your hands.
We got to make sure we're using soap. But this is a fun way, really. And if you work in like the medical profession, you've heard it referred to as a soap note. Is that it's talking about documentation. It's talking about the primary healthcare providers' documentation. And so it's subjective, objective, assessment, plan.
Okay.
And so
I get it.
Yeah.
I like soap notes. That could be that sounds like a good like funny little rap or something that we could come out with, like soap notes.
I know.
Well, I am learning a lot. And I think the last couple segments are going to be a little bit quicker.
Okay.
Because we talk about the emergency clinical response teams. And we know, like, too, it's department specific.
Yeah.
And when I was laughing earlier when we were talking about, like, pediatrics being peds, like NICU.
Yeah.
Then we have L&D for labor and delivery. And it's just so kind of, like, ironic that we're talking about this secret lingo, not so secret lingo and language of nurses when I'm sure it's probably been difficult for you. You've done a great job. You haven't used a whole lot of nursing terms to describe nursing terms, which I'm sure can be really difficult.
Yes. It's very
'Cause
hard.
it's very easy to throw in, some of those.
Yeah.
All right. So real quickly, Ashley, the last few we've got crash cart.
Oh, okay. And so this is you've heard of crash cart before, but you may not have put it together. So a crash cart is basically a cart, really is that you can move. You can take it in and out of the client's room, and whenever you have an emergency situation, you'll have things on that cart that are needed. There might be some emergency meds on that cart. You'll have IV start kit supplies. You'll also have other supplies like gauze and tape and things like that. But then it's also got maybe your ability to defibrillate.
Oh, that's where they're like, I need charge.
Yeah.
And it's like, dum,
Clear.
dum. Yeah. Okay.
Yeah.
Oh, a crash cart. Yeah, I have
Yeah.
heard about this. And of course, the medical shows. And you mentioned codes.
Oh, yeah.
So let's get into those. Code blue.
And so if you ever hear a code blue overhead, then that means, you have a client that is unresponsive. They're not breathing. You typically can't find a pulse. Or even if you can find a pulse, it's weak. And so if you ever hear code blue called out overhead, then you're going to have your emergency teams running to that client's room to get them stabilized.
Now, are a lot of the codes emergency specific?
Yes.
Okay. So code blue, code red,
So fire.
Yeah. Code black.
Usually code black is like a bomb threat, or it could even be an active shooter situation.
Okay. What other colors am I missing? Is there a green?
Okay. I'm not sure about green,
Okay.
but there is a gray.
A gray. Code
Yep.
gray.
Code gray is usually bad weather. And so if they say code gray warning, it's usually something like a tornado warning in the area. So gray is all about your weather.
I'm going through my colors here.
Yeah.
So orange?
Yeah,
No
I'm
orange?
sure I don't know about an orange, but there's
Okay.
pink.
Pink. Okay. Code pink.
Yeah. Code pink is an infant abduction. And so you don't want to hear
Oh.
that one called either. I mean, you don't want to really hear any of your color codes
Right.
called because all of those are emergency situations.
But I mean, it's a hospital setting, so codes are going to happen.
That's right.
Code pink. That sounds something like you really don't want to hear.
Oh,
called.
for sure. And the thing about a code pink is that if you ever hear it overhead, you want to treat it as if it's real, because sometimes they'll call codes a practice situation, but they won't inform you that it's a drill, because they don't want you to treat it as a drill. They want you to treat it as real.
We would do those in school.
Oh, for
Fire
sure.
drills,
Right.
tornado drills. Yeah.
And after the fact, you found out it was a drill,
Yeah.
right? And so if you ever hear code pink called out, there's certain things that you have to do. With every code, there's certain roles that you play. But with the pink, they shut the whole hospital down in most situations. The elevators stop working. The stairwells lock. Nurses are supposed to be positioned in certain places because we want to make sure, a baby is with their parents.
Yeah.
And not
so
getting
that
out.
one, that affects the whole hospital.
Yeah.
Whereas maybe some of the other ones, like a code blue maybe,
Right.
might be more geared towards the emergency department. So these other departments aren't, actively participating in it. Whereas a code pink, everybody.
Everyone. That's right.
Now, I did see it when we were going through some of these that there was a code blue hangover.
Yeah.
Explain this to me.
Okay, and so that is basically the feeling that's left in the room, or even maybe just the feeling that the client has. Because, that's a high-stress situation. It's a fast-paced situation. And so everybody's running around, everybody's doing their job. And then when you finally get that patient stabilized and everything is calm, you're really not calm yet.
Yeah.
It's like you're trying to get yourself back. And so the patient also has experienced all of that. And so it's the feeling that's left over, like the feelings of the client that they have, the feelings of the nurses, and then just the feeling in the room. It feels like a hangover. Like you've done a lot.
A code blue hangover.
Yep.
Okay.
And those are just some of the codes. Those were mostly the codes that are specific everywhere. Like everywhere you go, those will be universal. But when you work in certain places, in certain hospitals, they may have their own codes. And so they may have a special code that they call overhead for needing assistance. That might not be the same code word everywhere. And some places even have their own special code word for emergencies like an active shooter. So whenever you go to work, just make sure you learn your codes. A lot of places have those little badges where it tells you what the codes are on the badge reel. So whenever you go to work, if you need that, make sure you know what those codes are.
Good tip.
Yeah.
And I like that they would provide a little cheat sheet that they can like pull out and look at.
For sure.
Ashley, that was a lot to cover.
Oh, yeah.
And I feel like we probably just scratched the surface because I know that we even had some in the little game that we played earlier that maybe we didn't cover. So I can't wait to go back and re-watch this and to listen and say, oh, okay, like, yeah, we covered that one. And I'm probably going to be a little embarrassed on how I started this out at the beginning. It just goes to show that there is a language of nursing and they do have their own vocabulary, whether it be something that you can document or something that you don't document.
Right.
And I really, as always, appreciate your valuable insight and wealth of knowledge to help me and our listeners, most importantly, who may be intimidated by the language of nursing and, all the different abbreviations and terms and the charting cheat sheets. I think it's okay to say, oh, this is a lot. And clearly we know that you're looking for additional resources. And that's where we're happy that you tuned in to the Nursing Navigator today.
And guys, like Sarah said, I mean, there's tons more. I know we didn't get into all of them. There's probably some that you guys are learning in nursing school or maybe even have seen at your hospitals. Let us know, okay? Make sure that you DM us or maybe even just send us an email, nursingnavigator@hurstreview.com. We'd love to get those responses from you, and maybe we can tackle some of those in another episode.
Yeah. And for those that maybe are just listening and not watching, that is HURST.
Yeah, thanks.
REVIEW. Well, Ashley, thank you for breaking these down for me, being our translator, and as always, just providing additional insight to our listeners. But we're about to clock out, but not yet, because I want them to know that we release episodes Q7 days. We want you to become a frequent flyer. You can do so by hitting subscribe or follow down below. And we would love for you to submit your feedback in the show notes, comments, DMs, or by shooting us an email. Until next time, future nurses,
current nurses,
and retired nurses, thanks for tuning in to the Nursing Navigator by Hurst Review.
Guiding you through from school to the floor, nursing news, careers, and so much more. Learning, growing, passing the test. With Nursing Navigator, you'll be your best. Nursing Navigator's here.